Hi everybody, and welcome to our module on anti-tumor antibiotics. The anti-tumor antibiotics are drugs that are naturally occurring. They are all derived from strains of the bacteria Streptomyces, and we'll talk about a couple of drugs that fall under this category, including the anthracyclines, dactinomycin, and bleomycin. We'll start with the anthracyclines. There are a number of drugs in this class. The most important ones are daunorubicin and doxorubicin. There are also some others in this class, including idarubicin, epirubicin, and mitoxantrone. All of the anthracyclines have a four-ring structure like what's shown on the screen here. On the left side of the screen is the chemical structure of daunorubicin. On the right side of the screen is the chemical structure of doxorubicin, which often goes by its trade name adriamycin. Anthracyclines have multiple toxic mechanisms by which they can kill cancer cells. First of all, they've been shown to inhibit the enzyme topoisomerase II. I'll talk about what this means in a minute. This leads to breaks in DNA in cancer cells. They can also intercalate into DNA. I'll explain what that means in a few slides. This blocks the synthesis of DNA and also RNA. And then finally, they've been shown to generate free radicals. And through all of these mechanisms, they can kill cancer cells. And they are cell cycle nonspecific because they can attack cancer cells in any phase of the cell cycle. Topoisomerase II is an enzyme that relieves tangles and supercoils in DNA. As DNA is being replicated, it often gets twisted and tangled like this DNA strand I've drawn on the left side of the screen at the bottom. Topoisomerase enzymes can undo those tangles so that the DNA is straight again. It does this by cutting both strands of the DNA helix and then resealing the molecules, and this will relieve the tangles and supercoils that develop in DNA. When anthracycline inhibits topoisomerase II, the enzyme will break DNA but not reseal it. This will result in DNA damage, and this leads to cell death. Anthracyclines can also intercalate within DNA. This means they can bind to DNA and insert between base pairs. Shown on the screen is a drawing of a DNA double helix with lots of bases down the middle. The black lines here depict what anthracyclines can do. They can insert between the base pairs. This will inhibit the replication and also the transcription of DNA strands. Anthracyclines have also been shown to generate free radicals that are toxic to cancer cells. Shown on the left side of the screen, I've highlighted a portion of the anthracycline structure that's called a quinone. NADPH inside of cells can convert the quinone portion of the molecule to a structure called a semiquinone, which contains an oxygen radical. That oxygen radical can be transferred to oxygen, which can then become hydrogen peroxide, and in the presence of iron, this can produce hydroxyl radicals, which lead to DNA oxidative damage. So key points about this process are that it requires NADPH and oxygen as well as iron, and through these substances it produces free radicals which can damage DNA. Doxorubicin or adriamycin is one of the most commonly used drugs in this class. It's a very widely used cancer drug. It's used in most cases of breast cancer. It's also used in many other solid tumors. It's used in some childhood cancers, including neuroblastoma, Ewing sarcoma, and osteosarcoma. And it's also used in some cases of leukemia and lymphoma. A major problem with these drugs, and in particular with doxorubicin, is that these drugs can potentially cause cardiotoxicity. They can lead to systolic heart failure with a reduced left ventricular ejection fraction. This is believed to occur because the free radicals that are generated can damage myocytes and lead to necrosis. This is essentially like causing a diffuse mild version of a myocardial infarction. This can lead to a presentation consistent with heart failure, including dyspnea, fatigue, and edema. Most patients are screened with echocardiograms after an infusion to try and detect cardiotoxicity early, and this can be a permanent side effect of these drugs, so patients can be cured of their tumor but left with systolic heart failure. It's a very serious complication, and there is an entire field called cardio-oncology devoted to preventing and treating patients with cardiotoxicity from chemotherapy drugs, especially from the anthracyclines. Cardiotoxicity is rarely seen with lower total dosages, and for this reason, many oncologists will limit the total amount of anthracyclines that are administered to their patients in an attempt to reduce the risk of cardiotoxicity. There is also a drug called dexrazoxane which can be used to prevent cardiotoxicity. It's an iron chelating agent, and there are data that it limits anthracycline-induced cardiotoxicity. The problem with this drug is that there are also some data that it interferes with the benefits of the chemotherapy agents, and for this reason dexrazoxane is only used in special niche circumstances. Our next anti-tumor antibiotic is dactinomycin. It's also called actinomycin D. Just like the anthracyclines, it has several mechanisms by which it can kill cancer cells. It also can intercalate in DNA. It's been shown to inhibit RNA synthesis and transcription of DNA. It's also been shown to induce double-stranded breaks. This drug is commonly used in childhood cancers, especially neuroblastoma, Ewing sarcoma, and osteosarcoma, and its major adverse effect is myelosuppression. Our last anti-tumor antibiotic is bleomycin. Bleomycin binds to DNA and it can generate free radicals using oxygen and iron via a very similar mechanism to the anthracycline mechanism we discussed earlier. It's also been shown to lead to single and double-stranded DNA breaks. This drug is unique among the anti-tumor antibiotics in that it is cell cycle specific. It is specific for the G2 phase, and this is because this is the phase in which it accumulates during cells, and therefore most of its effect is in the G2 phase. Bleomycin is used in lots of different malignancies. It's used in lymphomas, germ cell tumors, head and neck cancer. It can be used in squamous cell carcinoma of the skin and also in cancers of the cervix and the vulva. To understand the toxicity of bleomycin, you need to know that it is inactivated by an enzyme in the body called bleomycin hydrolase, and there are lower levels of this enzyme in the skin and also in the lungs, and therefore the toxicities usually occur in the skin and the lungs. In the skin, many different skin changes have been described among patients receiving bleomycin. These skin changes are also seen with some other chemotherapy drugs, including busulfan, which sounds a lot like bleomycin. One of the classic but rare skin changes is called flagellate erythema. These are red dark streaks on the skin, and they have been described in patients receiving bleomycin. There are a number of chemotherapy agents that are known to cause pulmonary toxicity, and bleomycin is one of them. Pulmonary toxicity is the dose-limiting adverse effect. It usually presents as pneumonitis, so patients develop inflammation in the lungs. This can cause cough, dyspnea, and crackles. It can also lead to infiltrates on chest x-ray, and also infiltrates that can be seen on a CAT scan like this one shown on the screen. This is more common in patients who are older. It's also more common in patients who have a prior history of pulmonary disease. And that concludes our module on anti-tumor antibiotics.